my name is Omar Chikovani. I'm a pediatric critical care doctor with 20 years of medical experience in the United States. I work at Swedish Medical Center in Seattle, Washington, and our hospital was one of the first in the United States to see influx of COVID-19 patients. And I'm a witness to this. I had many interesting observations, many discussions with the medical staff in emergency room, and also I came across a large amount of new articles on the web that are coming from all over the world, and I combined all that information with my own clinical experience and knowledge, and all this morphed to this presentation, and I hope you'll like it. A little bit about my background also. In addition to the pediatric critical care, I have experience in pediatric cardiology, and also I did my research fellowship at Pulmonary Hypertension Lab at University of California, San Francisco Cardiovascular Research Institute under guidance of Jeff Fineman. So let's talk about this virus, which is a novel coronavirus. And our scientists were very fast to kind of figure out this gene sequence in this virus, and they actually could replicate the RNA completely, and they figured out that it looks very similar to other coronaviruses known to us, but there's one key difference, and this key difference is the spike protein, which is unique to this new virus. None of the other viruses have it, and this is very significant, and we'll talk about it many times. So this spike protein, which is the key, and how it acts, it actually acts like a key. It attaches to angiotensin converting enzyme 2 receptors, and that's how it enters the cell. So this key gets into the keyhole, which is this receptor, and then that's how the virus enters the cell. So it pretty much acts like a drug, losartan, which decreases your blood pressure. So the virus has many small losartans on it, and that's how it works. Actually, that's its weapon. So let's see how it enters our body. So initially we thought that it's inhalation. So the primary mode of entry into the body is inhalation, and then you can get it through mucous membranes and eyes. And then just recently, this came out like 4 days ago. There were articles saying, you can actually contract it if you ingest it. So in fact, fecal oral route is the mode of transmission. And I would suggest, or I would speculate, that this is the primary mode actually, but not inhalation. And I'll explain to you why, and then we'll go back to the basics again, and we're going to talk about ciliary cells. So ciliary cells are little cells that line up all your respiratory system, and they have those little tentacles, and those tentacles are acting, and they're basically moving constantly, and they're bringing up all the dirt, all the bacterial viruses that you inhale into your respiratory system up, and then eventually you swallow them. So that's the purpose. That's the defense mechanism that body has against invasion of different toxins or different microorganisms. So there are people who don't have those ciliary cells well functioning, so their cilia are kind of silly. Those people have genetic disease called Carter-Jenner syndrome. So those kids end up in the hospital on a very frequent basis. They come in with multiple infections, pulmonary infections, viral or bacterial, because their cilia are silly. They cannot work because structurally they have a genetic defect that affects the structure of those cilia. So they're not as motile, and they cannot function well. But the other interesting thing is that ciliary motion is suppressed by cigarette smoking. So if you smoke a cigarette, it stops or halts the motion of those tentacles for 3 hours. So that's why probably that smoking is one of the risk factors in this disease, because lots of articles kind of put smoking next to the hypertension or diabetes as a risk factor. And that makes sense because it basically kind of alters or makes your first line of defense kind of weak. So inhalation, I don't think it's the primary mode. Even if you inhale small amount of viruses, it will still, like, action of the ciliary cells will come up and then you'll ingest it. If you inhale large amount of virus, like the patients or individuals that inhale like humongous amount of virus, and your ciliary cells might not be able to handle everything. And those are the people who are in medical field, basically. Those are the people who are intubating those patients with active disease, or the ones that are interacting with those patients very closely, and you can inhale a large amount of virus at once and it will spread into your lungs. And yes, then ciliary cells might not work at that point or in that case, but usually you are not seeing that, because not many people do intubations, right? So in general population, you do not get that huge amount of virus at once. You get a little bit, and then it eventually ends up in your digestive system. And that's why we're seeing more and more articles saying that people have diarrhea, anorexia, vomiting. So this is also a new development. Not many articles are saying that this is the leading symptom, and everybody's concentrated on this: cough, fever, tiredness, and difficulty in breathing. The fever is also not the essential part of patients' symptoms. So again, I would argue that this is actually the major and primary symptom. The digestive symptoms are primary rather than this, because the primary mode of acquiring this disease is through the digestive system, and it will basically break down things very logically. So this is going to be stage one. So you ingest it, and then the first line of defense is in your gut, and then you get all the gastroenteritis, right? So, and the mesenteric lymph nodes are gonna be the ones responsible for first line of immune defense against this virus, right? And if your immune response is adequate, it will get contained at that stage, so stage one. And that could explain also why kids are not getting sick as much as adults, because they put everything in their mouth, and they basically get this disease through fecal oral route, and they get good immune response. Like most of the kids have good immunity, and they basically handle this disease on the first stage, which is a gastrointestinal stage. Well, around me, there were lots of people who I know, like pediatric patients, who had diarrhea for a day or two, and they were fine afterwards, and that's it. And those are the kids who actually contracted the disease and got better because their immune response was normal. And that applies to the majority of population, because majority of population has normal immune system, and they can handle this virus relatively easily. But if there's an inadequate immune response, then this virus replicates in your mesenteric lymph nodes, and guess where it goes? It goes to your lungs, like a metastatic GI cancer. And the lymphatic system is very interesting from this standpoint of view. Like the mesenteric lymph nodes, if you remember, from anatomy, it connects into this huge lymphatic vessel, which is called the thoracic lymphatic duct, and it drains into your subclavian vein. I mean, people who have worked in the pediatric cardiology, cardiac surgery, they know that if you injure this duct, you'll have like pylothorax, right? So, and you have to put those patients on the low-fat diet, because otherwise you'll see this chyle coming out on a constant basis with large amounts. So you put those people on a special diet so that do not generate much of a chyle and this duct heals. But in this case, all these viruses are coming through this duct and then coming to the superior vena cava and eventually end up being spread to the lungs. And the lungs are going to be your second line of defense. So the first line was intestines, and then the second line is lungs. And then let's go to the spike protein now, and then figure out what this will do to your lungs if it spreads there. Let's go over the basic pulmonary vascular physiology. So in pulmonary vascular physiology, it's very interesting. It's very different from other parts of the body. So if you're hypoxic, if your oxygen levels are low, your pulmonary vessels will constrict. And then if you have enough oxygen or lots of oxygen, they will vasodilate. If you're acidotic, if you have acid buildup in your body, pulmonary vessels will constrict. If you have alkalosis, your pulmonary vessels will dilate. And here's your second stage. So that large amount of those viruses are coming to your lungs now with those weapons. Remember those weapons, the spike proteins? And they will infect your lungs, and they cannot infect everything at once, right? So they will infect some parts of your lungs, and they will cause inflammation and infection in those parts of the lungs, and then they will cause this, okay? So they will cause inflammation, they will fill those air-filled sacs, usually they're open, right? So this is a normal alveolar unit, this is the diseased alveolar unit, right? So in this one, you have virus with its spike protein, and this virus with spike protein is affecting your vessels by dilating them, okay? They're dilating the vessels, and by dilating the vessels, your resistance in those parts of the lung which are infected by this virus is going down, the vascular resistance. At the same time, the vascular resistance in the normal lung is going to decrease, and I'll explain to you why. Because there's a less resistance here as opposed to the normal lung. The blood is going to be channeled to those parts. So it's just the law of physics. The blood or the liquid is going to move towards the less of the resistance, and you'll have this ventilation perfusion mismatch. And if we go back to this basic physiology, you'll understand that if you get most of the blood shunted to the areas of the lung that are infected and non-functional in terms of gas exchange, right? So if you have lots of blood coming here and you cannot actually have a gas exchange in your alveoli because they're inflamed and they're filled up with pus or inflammatory fluid, you're going to basically it's a waste, basically. You're not going to be able to get blood oxygenated, so pick up oxygen, and you're not going to be able to get rid of your CO2. So, and then also at the same time, you're going to be stealing the blood from your normal parts of the lung and basically depleting those parts of the lung from working appropriately, and they basically cannot enrich blood with the oxygen because there's no blood flow there, or it's very little. And it creates this vicious cycle by making patients hypoxic. And hypoxia, again, it causes pulmonary vasoconstriction, right? So this will affect those vessels even more and shunt blood even more towards affected areas, the infected areas, right? And if you don't have much of an oxygen in your body, you start making lactic acid, which will by itself cause pulmonary vasoconstriction. So you have like three things working against you. You have you have blood flowing towards route of lesser of a resistance. You have vasoconstriction because patients are hypoxic, and plus you have pulmonary vasoconstriction because patients are acidotic. And most of the blood basically is being shunted here. If you do an echo on this patient, guess what? The pulmonary pressures or right ventricular pressures are going to be fine, and you are not going to see classic pulmonary hypertension picture because not all of your lung is affected at the same time, and you kind of achieve some sort of equilibrium that will not produce right ventricular, increasing right ventricular pressure. And then that's where pulmonary vascular dilators come to help in this condition, right? So if you give somebody inhaled nitric oxide in this type of situation, when you still can ventilate those normal lung portions, but you don't have the adequate blood flow there, and that inhaled pulmonary vasodilator is going to start reversing those effects of hypoxia, as well as the acidosis, as well as the the resistance is going to basically decrease. So you'll equilibrate, you'll start shifting the blood towards your normal parts of the lung because you'll reduce the resistance in those vessels, and you're going to start oxygenating your blood way better, of course, and then you'll start seeing clearing of your acidosis and your hypoxemia, and that's what is the key in that stage to help those patients. So there are many pulmonary vascular dilators, right? So nitric oxide is most commonly used in pediatric population, but adults use Flolan a lot. I haven't used those two, but I've used nitric oxide and Flolan, mostly nitric oxide, with very good results in pediatric patients. I remember when we had a epidemic of H1N1, we used nitric oxide a lot in our unit in Honolulu. I worked in Honolulu at that time, and it did help. It did help tremendously. What about the oral pulmonary vasodilators? So if these patients are already in advanced stage of the disease, oral pulmonary vasodilators might not work as well because they also have systemic effects. So the best way to deliver pulmonary vasodilators is by inhaled route, because they will basically target the alveoli that are actually suffering because they don't have enough blood flow. So, but their airway is still open here, and their unit is still intact. They have normal function in alveoli. They just need blood. So you inhale nitric oxide here, and then it will dilate those vessels, and you have increased blood flow, and then you will basically correct your problem. So let's see. Inhaled nitric oxide. So it's selected pulmonary vasodilator. It only dilates pulmonary capillaries and alveoli participating in the gas exchange, okay? And it decreases your interpulmonary shunt, and it doesn't have any systemic effects because it's basically inactivated right there at the lung level. And in adults, there are many articles about use of inhaled nitric oxide in ARDS, and most of those articles are from adults. But in pediatrics, again, we saw a lot of improvement, and although those articles are saying it doesn't affect your overall morbidity and mortality significantly, like by those p-values, but who cares about the p-values when you see, like clinically, we saw a lot of improvement when we had this H1N1 epidemic in 2009, 2010. It was very vivid what we saw. But unfortunately, FDA approves it just for pulmonary hypertension. Also, it's very expensive, and the modes of delivery are like, you can actually deliver it in any way you want. You can deliver it through nasal cannula or high flow or regular. You can deliver it by BiPAP, or you can deliver it by intubation. But the thing is, you do not want to get to intubation stage with those patients. It is the key, actually. So because if you intubate those patients who are in that very bad physiologic complication, physiologic stage, when you have that bad BQ mismatch, you'll actually cause more trouble. You will increase, positive pressure ventilation will actually cause you to have more problems because it will exacerbate your BQ mismatch even more. And then if you cannot handle this virus on that lung level, then you go into this third stage of the disease, and it's systemic stage. So you cannot contain it in your lungs, which is this like third line of defense. Remember, the cilia was the first line, and then probably stomach acid and cilia together was the first line, because stomach acid will break up your virus and will reduce your viral load pretty significantly. And then the second line of defense is your lungs, and then the third line, if your immune system cannot handle this virus on the lung level, it will spread, and like in metastatic cancer, it's going to go everywhere. So remember, GI cancer first goes to your lungs and then spreads everywhere else. The same is with the virus, and that's when you get cardiovascular collapse. Remember the key protein starts to work again. That's spike protein. It will affect your vessels all over your body, and you'll have a cardiovascular shock, okay, cardiovascular collapse. So those are three stages. So there's a GI stage, and then you have pulmonary stage, and then you have systemic stage. And there are plenty of research opportunities for you guys, because I think we should start testing those patients' stools, because there are a lot of instances when they actually have pulmonary findings on the CT, but their PCR from the nasopharyngeal swab is negative. And that makes sense because the virus hasn't made it up. It's still kind of sitting on the periphery of the lungs. And then also you can do like serial cardiotectin levels to kind of figure out what is degree of your inflammation in the gut. And you can also do serial hemocolt levels, because a lot of patients, if they will have significant gastroenteritis, they will have like some heme positive stools, and that could be like, if you're clearing your heme positive stools, then it means that your gut inflammation is going down. So again, mode of entry, it's ingestion. The first is ingestion, and then inhalation, and then this is very uncommon. So I think it's ingestion. It's fecal oral route, or the virus enters our body through the gastrointestinal tract rather than from the lungs as a primary entrance point. Again, potential research also, serial procalcitonin levels. This is very important in the second stage, because a lot of people are reporting that you have co-infection with other diseases, like up to 20% of the patients can have bacterial or other virus at the same time. So serial procalcitonin levels are going to help you to initiate antibiotic treatment early, so you do not get double whammy on those patients. You do not get viral infection plus bacterial infection at the same time in your lungs. So I think this is very important. We do this all the time in pediatric patients when they come in with respiratory viral pneumonias, and we are pretty aggressive with starting antibiotics early on if procalcitonin levels are high. And again, the spike protein. Spike protein is very, very important, and you have to target this spike protein to conquer this disease eventually. And again, potential research topics about the spike protein. You can actually develop or replicate the spike protein and give it as an oral or rectal vaccine. If you give it orally, it might get degraded by stomach acid, but if you give it rectally, it will not get affected as much. And the other thing is, you can develop the spike protein specific antibodies like IVIG. We use IVIG all the time, right? So it should be spike protein specific IVIG. And also you can use the spike protein for treatment purposes in the patients, because you know what, spike proteins are little losartans on the virus's body, so why don't you use them and basically target those cells that you need to by figuring out, you have to figure out how to do it, but I'm sure you guys the scientists can do it pretty easily, or maybe not very easily. So thank you very much. I hope my presentation was making sense to you, and if you like it, let me know. Thank you very much.